Well, on behalf of the organizers and the panelists, we, the organizers and panelists, are ready. So welcome back, everybody, to the joint LSE-Oxford seminar. This is our third installment. Today we have Simukai, Chigudu, and Kate Meagher speaking. COVID drama in Africa, Tales of the Unexpected. And they'll each speak for 10 or 15 minutes, and then we'll have the Q&A, the regular routine after that. So I'm going to turn it over now to Simukai to kick it off. Before I do that, just the usual announcements. Make sure that your microphone's on mute if you're not speaking. And I think that for this session, if you have any questions, oh yeah, put your questions in the Q&A button at the bottom, and then I will, as host, read them out. So I don't think actually you can speak. You're all muted. So if you have questions, pop them into the Q&A box, and then I'll be the moderator at the end. Okay, Simukai, over to you, please.
Okay, great. Thank you very much to Ken and Diego in particular for organizing this, and for Laura for putting this, broadcasting this and getting the promotion and recording done. My name is Simukai, and I'm going to be speaking today about tackling this question of essentially the conceit of our session on the COVID drama in Africa. What do we mean by drama? And I'd like to suggest over the next 15 minutes or so that as we witness the COVID-19 pandemic spreading across the world, we start to make sense of it according to a series of tropes and narratives that we might understand as a kind of dramaturgy. That's going to be my entry point into today's discussion. So I'll begin with some kind of theoretical or intellectual outline of what I mean by the dramaturgy of epidemics. This will allow me to think a bit more specifically about the sort of dramaturgy that has accompanied COVID-19 and where Africa sits within this wider outbreak narrative. I then want to suggest that outbreak narratives have been setting up a series of projections as to what might be happening in Africa. And yet empirically, we find Africa defying many expectations and predictions embedded within the outbreak narrative. And I think that that then has some crucial implications for development studies and for us as a scholarly community in terms of how we think about, talk about, and study the unfolding phenomenon. And I'll end with a few concluding thoughts, which hopefully should dovetail quite nicely into Kate's portion of the talk. Okay, so what do we mean by dramaturgy? This framing is inspired by the historian of medicine, Charles Rosenberg, who famously wrote in the 1980s that epidemics have a dramaturgical character. They're rendered intelligible as social phenomenon through stories or narratives that follow a familiar pattern. As such, epidemics start at a moment in time. They proceed on a stage limited in space and duration, all the while following a plot line of increasing and revelatory tension before they move to a crisis of individual and collective character and finally drift toward closure. But that's not all. Rosenberg doesn't stop there. And instead he goes on to suggest that a key dramaturgic aspect of epidemics are that they take on the quality of a pageant. In so doing, they mobilize communities to act out a series of rituals. And yet these rituals both incorporate and reaffirm fundamental social values and modes of understanding. So we might come to understand this pageantry, these rituals that accompany epidemic narratives a bit more precisely through what the literary scholar Priscilla Walls describes as the outbreak narrative. Now, the outbreak narrative is made manifest across multiple genres of writing. These include scientific forms of writing, journalistic accounts of how outbreaks unfold, and fictional incarnations of the story of epidemics. And it's a pattern that we've seen repeated throughout time across many different parts of the globe. The outbreak narrative follows a formulaic plot, and it always begins with an emerging infection, It then includes a discussion of the global networks through which an epidemic might travel, and it chronicles, the narrative chronicles the epidemiological work that goes into bringing an epidemic to its conclusion. One of the most kind of outstanding examples of this outbreak narrative is exemplified in the journalist Laurie Garrett's work and her 1994 book, The Coming Plague, which posited a quite dystopian vision of the future in a world overrun by new emerging diseases, often exotic viral infections such as Ebola or hantavirus found in dense parts of Africa's forests. And it's no coincidence that Garrett's book, The Coming Plague, shares a narrative framing as Robert Kaplan's essay, The Coming Anarchy, which was published in the same year of 1994. Again, another famous treatise that offered a dystopian trope of how crime, climate change, migration, and in this case, infection emanate from Africa and illustrates the dangers of globalization. I think what's kind of key about narrative outbreaks is that while they're formulaic, they're also tremendously flexible. They allow for a wide variety of actors to adopt the outbreak narrative, molding small parts or emphasizing particular elements and downplaying others to suit their own purposes. The outbreak narrative kind of furnishes us with a consistent and self-contained ontology of epidemic disease. Through the outbreak narrative, we come to understand epidemic disease as adhering to very specific causes and consequences, having distinct patterns and prospects, grouped together by a constellation of risks. And the outbreak narrative then posits the most appropriate methods for preventing or managing those risks. And so what I'm suggesting here then is that outbreak narratives actually embed within them not only a scientific account of how infections spread throughout the world or in a given geography, but they come coupled with a moral economy and a historical account. And this historical account invariably has heroes, pace, and plot. It equips us with a ready vocabulary for ascribing blame for failures and assigning credit for triumphs. And it's this universalizing template of the outbreak narrative, however flexible it might be, that ultimately shapes a predominant way or prevailing way of understanding human microbial interactions and guiding the conditions of possible response to outbreaks. So to concretize this narrative outbreak framing, we can look at how some of these dynamics have been playing themselves out with respect to COVID-19. So here, the COVID-19 narrative outbreak that's been kind of predominant in public commentary begins in the wet markets of Wuhan. For many Western observers in particular, we get the sense of an exotic and foreign location stoking anxiety about humanity at an ecological brink, in which unregulated interspecies mingling might tip us or tip humanity into collective destruction. From here, the drama intensifies as the virus spreads through the circuits of global modernity, the economy, trade, finance, and tourism. And in the process, it becomes an international security threat, as well as a parable about the dangers of our interconnected world. And as we've seen with COVID-19, the outbreak narrative that's accompanied it is not fully coherent and is marked by a series of contradictions. It elicits disparate reactions about the obsolescence and tenacity of borders. So, for example, we're frequently told about how pathogens, viruses don't respect borders on one hand, and yet at the same time, the logics of quarantine and national shutdowns, of exceptional responses in given countries kind of reaffirm the very social power of borders. The story of COVID-19 is tied to various sub-stories about the threat and benevolence of strangers, and ultimately about both the failures and redemptive potential of medical science. And so in this way, even despite these contradictions, the outbreak narrative has tremendous potency in setting the terms of social dialogue and political debate. Africa, in the COVID-19 outbreak narrative has been discursively placed as the virus's final frontier, where we are assured it will yield untold damage. We have numerous headlines by journalists, policymakers, and scientists warning us of a ticking time bomb on a continent that's woefully ill-equipped to cope with the disease. In some of the wider commentary that's being published on this, we kind of see an intermingling of legitimate concerns about weak health systems in many parts of the continent, densely populated urban centers, and a history of devastating epidemics being entangled with more racist or pejorative ideas about the primordial nature of African poverty and about the inability of African peoples and governments to respond with ingenuity to this crisis. So contrasting the horror of COVID-19 in the global north with its presumed trajectory in Africa offers an important yet ignored political question about how and why the suffering induced by communicable diseases is treated as unthinkable in one place and yet inevitable in another. So I mentioned earlier that a key part of the outbreak narrative is the role of science and epidemiology in bringing about closure. And as one sort of reads the history of outbreak narratives across different literatures, there is a kind of recurrent theme of a sanguine reliance on science and a kind of fundamental belief that humanity will survive the coming plague intact. And within these narratives, there's even a tacit assurance that global transformations will not and should not significantly reconfigure social existence. With respect to COVID-19, there was this incredibly gripping story in The Guardian that did a deep dive into a Cambridge scientist's efforts in looking for a vaccine, how scientists are communicating across the globe, what forms of innovation in molecular biology are currently at work, and that can be seen here. And yet, of course, conspicuous in its absence was any mention of the African continent as a site of any kind of ingenuity or innovation. That's only reinforced by this image here, this global map of where COVID-19 vaccines are in development around the world. And we see, of course, large parts of the global south and Africa specifically totally out of the kind of scientific picture, suggesting that Africa exists within this outbreak narrative as somehow out of modernity, not the site where innovation or scientific ingenuity can occur, but a place that is somewhat passively waiting for disaster to strike. And yet at the same time, empirically, we know that the story is a bit more complex than this outbreak narrative, or at least the hegemonic kind of framing of the outbreak might suggest. So for instance, nearly a week ago, on the 22nd of May, the COVID-19 reached a new milestone in which the WHO reported that 100,000 confirmed cases had been confirmed in Africa. The virus at that point had now spread to every country in the continent since the first case was confirmed in the region 14 weeks ago. And yet the WHO also observed that despite Africa crossing this threshold of 100,000 cases, the pandemic, which had already struck so much devastation in much of the world, had taken on a different pathway in Africa. So case numbers, as you can see, have not grown in quite the same exponential rate in Africa as they have in other regions, nor has Africa experienced the same high levels of mortality yet. So here, for instance, we see that the total number of confirmed cases as of this morning, when I last checked, are about 120,000 cases, with 50,000 recovered, and then nearly 4,000 people have died. Now, if we compare that to the United Kingdom, the UK actually has more than double the total number of confirmed coronavirus cases as Africa does as a whole. And yet, in showing this somewhat unexpected picture, we can't afford to be complacent or smug in our analysis. Cases continue to rise in Africa, and crucially, it took 52 days to reach the first 100 cases, and yet it only took 11 days to move from 30,000 to 50,000 cases. Moreover, the pandemic remains a major threat to many countries' health systems, and new WHO models suggest that if current containment measures fail, even with a low number of cases requiring hospitalization compared to the global north, then the medical capacity in Africa would quickly become overwhelmed. Okay, so we have this framing of the WHO that Africa has taken a different pathway, and intense debate trying to explain why Africa has defied the very initial expectations that were laid out, as I already mentioned. So among the factors that we see being sort of posited for Africa's exceptionalism as such, one is a question of demography. So Africa's population is substantially younger than many other parts of the world. Indeed, we are it's the youngest continent, with more than 60% of the continent being under the age of 25. And as we know, older adults have significantly increased risk of developing severe respiratory illness and associated complications from COVID-19. So in Europe, nearly 95% of deaths have occurred in those older than 60 years. But yet this youth dividend is complicated by comorbidities, particularly the presence of HIV infection, malnutrition in many parts of the continent. So it becomes quite difficult to read what exactly the population profile means across Africa. And I think Kate will do a more particular job of narrowing this down for us. The other factor that's been posited is one to do with geography. So I've sort of written here slightly tongue-in-cheek that we have a version of Jeffrey Herbst's argument but applied to microbes. So Herbst, Africanist political science, wrote that African states struggle to broadcast their power from city centers into their hinterlands, which are sparsely populated. So we see a loose analogy of the microbe itself failing to broadcast its own power outside of populated urban areas. So that argument has kind of been floating about. We also know, closely related to geography, are the uncertain effects that temperature and warm weather might have on the epidemic, either indirectly by modifying social behavior and not putting people into quite close contact, or less credibly the impact of warm weather on the virus itself. So those ideas have been posited. We of course already know, and Kate will be discussing this in a bit more detail, that many African countries put in preemptive lockdowns, in some cases really quite stringent lockdowns, shut down global travel even before any single case had been reported. And many parts of the continent are not as integrated into the global economy, certainly compared to their European counterparts, but we also see that it's South Africa and Egypt with the densest networks of travel and commerce that have been most affected by the outbreak. And then there has been some more fringe speculation about a potential protective effect of BCG vaccine given against tuberculosis and widely used across Africa as conferring some kind of immunity against COVID-19, what I'm calling here imagined immunities. But the truth is that amidst all of these different projections, models, and scenarios, there is a tremendous degree of uncertainty. So when we even modify a few epidemiological models slightly, taking into account or working on different assumptions about travel and human contact and so on, we see that we don't actually know as yet whether Africa is in a pre-peak phase of the epidemic curve. In other words, what we're seeing in Africa is just the beginning, and we're still waiting for the continent to reach the level of exponential growth in the number of cases. And that's one of the anxieties that I have. There are some models that suggest we could be at the beginning of the end, that Africa has already had a peak, it just happened to be very low, and we're witnessing a steady decline, although I think that we can't be too optimistic about that. And then a third answer, or a third scenario, is that COVID-19 is in fact already endemic. in Africa. And so the reproductive number, the R naught, when we multiply this against the number of susceptible cases, amounts to 1. In other words, the epidemic is not spreading in a kind of geometrically like exponential rate between those still susceptible, but it's not falling below 1 and therefore can't burn itself out. It's in a kind of steady state. Okay, so what does all of this mean then, thinking about it from the perspective of development studies? I think what I've laid out thus far then should tell us that the kind of dominant model that emerged very early on in responding to the outbreak that was pushing towards a kind of flattening the curve. And so this image here on the left of the screen, emblematic of this move, that we need to implement social distancing and other lockdown measures in order to lower, like to flatten the curve of cumulative incidence to such an extent that the number of new infections does not overwhelm healthcare system capacity. This was the kind of primary objective circulating in the North Atlantic world, at least. Now, granted, there's a huge amount of variety between countries, but this is, I think, a model that we're familiar with. And yet, it's quite clear, increasingly across the world, and certainly within Africa, that this model cannot be entirely universal, as it's predicated on certain assumptions about the patterns of epidemic spread, the effectiveness of lockdown measures, but also about the capacity of economies or governments to cope, to absorb economic shock that comes from the suppression of economic activity, and also the speed and capacity of the medical profession and the scientific community to find an exit strategy out of the pandemic, while also being able to treat those who are suffering from the disease. And so the kind of cliche that's now been spreading around remains eminently true. This one-size model does not fit all, and that we need to have a slightly more expansive and nuanced view of this interaction between medicine, public health, and the economy. And in Africa, across the continent, we're actually seeing a variety of both possible and actual responses. Crucially, across the continent, there isn't really a monopoly of institutional entity taking control of this. So I've been in meetings and calls with colleagues in Sudan, in Kenya, who are documenting the variety of ways that local communities are responding to the management of the outbreak, or are implementing a kind of communal epidemiology, identifying safe spaces for lockdown and communicating or documenting where illness is occurring. But this is all a bit haphazard and locally specific. And so I think that the challenge then becomes grappling with a series of tensions and trade-offs. I've already talked about this kind of tension between livelihoods and how they're affected by the shutting down of economies, as well as the imperatives around quarantine for public health, the tensions between state-led and community responses, and also crucially in terms of health system capacity, some of the tensions between the gold standard evidence-based medicine, including how you treat people with severe acute respiratory distress, versus what many doctors that I've been speaking to are telling me, say for instance in Zimbabwe, about the lack of ventilators and therefore the need to improvise treatment, to improvise use of personal protective gear, to improvise treatment protocols and so on. And then we can situate all of these questions within larger dynamics happening across the continent, pertaining, say, from the bottom-up level to mobility and migration, which remain particularly crucial in informal economies, as well as the wider questions about Africa's fiscal space to cope with economic shocks. And then going back to the outbreak narrative, I think that development scholars are kind of well-placed to start to critique the outbreak narrative, which I've suggested glosses over a huge amount of context and complexity. But I'd also go a bit further than that. The outbreak narrative does not only provide us with a universalizing template, but the reflex to anticipate catastrophe in Africa creates this anticipatory regime. And as Vincan Adams and Betsy Hartman and a number of other scholars have written, anticipatory regimes kind of hinge or project a future that may or may not arrive, is always uncertain and yet is necessarily coming, and so therefore always demanding a response. In other words, we're kind of locked into a modality of thinking that says we have to act on the worst case scenario before a full appreciation of the empirical realities. Anticipatory regimes then can belie politics and political agency, replacing actors and institutions with impersonal forces such as microbes, and they reinforce a potent but narrow model of development predicated on a vision of African weakness and failure. And finally, anticipating pandemic catastrophe results in a kind of disease exceptionalism, where health systems become entirely oriented towards a single pathogen. And therefore, we think of Africa's public health constantly moving from one crisis to the next: HIV, Ebola, and now COVID-19. And this undermines, wider health system strengthening, can result in contingent forms of health citizenship that leave people with access to treatment or to public goods based on their biological status. And so to conclude here, I just want to kind of reinforce the idea that yes, real risks, but also real tragedies exist in Africa as they do all over the world. And the region is not exceptional in terms of waiting for catastrophe, but we need to contend with its empirical reality, particularly given the lack of a clear blueprint for dealing with this pandemic. And as we sit between the knowns and unknowns of the epidemic, we can productively turn our attention to the taken for granted, that category of being that naturalizes the threat of a microbe. And we can start to think about the conditions that create epidemics, that allow viruses to go viral as such. And fundamentally, to challenge one of the conceits of the outbreak narrative, that science alone won't save us, and we need to rethink political economy because we can't go back to normal. Okay, I'll conclude there.
Thank you very much, Simukai. Off to a great start here. Lots of interesting things to talk about. Remind the audience that if you have questions, to pop them into the Q&A, and then I'll work as moderator after Kate's done as well. So Kate, I'll turn it over to you now. Kate, you're on mute, so make sure.
Okay, am I making noise?
Yeah,
Great.
you're good.
All right, thank you very much. I'm just going to put up my own screen here. It's wonderful of all of you to come on this Zoom afternoon to hear us talk about the COVID drama in Africa. I think we're really trying to look at the narrative, but also at the way that things are shaping up in a very different way. And to understand a bit more about how things are going within Africa, as well as between Africa and the rest of the world. So this is very much also a tale of the still in reflection. I've been piecing together things, and this is a work in progress, I would say, at this stage. Oh dear, the screen is not moving. Okay, there we go. All right, so I'm going to try to pick up essentially where Simukai left off and think about the way that the corona drama has been framed in Africa, starting with the idea of dire warnings about how terrible it's going to be. Bill Gates was talking about the specter of 10 million deaths in Africa by the end of this year. The WHO was modeling something in the range of 200,000 deaths, but have downscaled it now to about somewhere between 83,000 and 190,000 deaths. Melinda Gates was talking about bodies in the streets. I mean, really dire predictions of how terrible this is going to be, and the need of the global community to come together and rescue Africa. It was really very, very central to the narrative. And for a while there, those of us who were watching what was going on in Africa were thinking, doesn't really look all that bad, I wonder. And I think Simukai has given the feeling of the ways in which a variety of forces, demography, weather, previous disease experience, issues of testing, and I'm going to raise these all as we go along, have come into the narratives of why things don't look so bad. Some people are saying that there are reasons why there is a different path. Other people are saying it's actually worse than it looks. They're just not testing properly. And I'd like to talk a little bit about lockdown debates and the ways in which the debate about lockdowns in the African context are reframing thinking between those who focus on the health side of the debate, the need for lockdowns and to avoid catastrophe and mobilizing huge amounts of aid around vaccines and palliative measures for people who are too poor to lock down without support. And the economic arguments, which emphasize the ways in which many people in Africa aren't able to survive a lockdown, partly global value chains, partly large informal economies where people have to work every day in order to eat. And then there's a tension between these two arguments, but I also want to focus attention on something Simukai touched on as well, other health challenges and some of the realities of authoritarian politics, and really the wider problem of cut and paste policy templates, a tendency from the structural adjustment era really of encouraging African countries to cut and paste policy templates from the West, whether or not they're appropriate to the context. And then I'd like to look a little bit of the variations in African responses to the epidemic or the pandemic, and try to understand how those differ from each other and what we can learn from those variations, at least so far. And a few words finally about the corona drama going. So here. Can I go backwards at all? Okay. My screen is a little bit in my way here. So this gives you a reading of coronavirus deaths by region, just to give you a sort of pictorial understanding of how serious the epidemic is in Africa. The yellow is Europe, as you can see, and it's really quite clearly very bad, and you can see that characteristic upswing and then the beginnings of a downswing. The orange is America, and Africa is this blue right along. I don't know if you can see the arrow, but you can just see a little blip at the very, very bottom there. So really, compared to other countries over quite a long period of time, the level of corona deaths in Africa have been extremely mild. Now, if we look at a more contained set of cases, I just plotted from the first death, the UK experience against South Africa, which is a comparable sized country, and Nigeria, which is actually about 200 million, which would be roughly 3 times the population of the UK and South Africa. If you look at the UK experience in numbers of deaths from the first death, not in calendar time, but just from the first death, you can see a huge takeoff from week 3. Whereas in South Africa, it's pretty mild. And in Nigeria, even more mild. And many people say, well, that's because there's no testing. But the evidence from South Africa is that their testing has been pretty good. About 1 in 10 South Africans have been tested. They have a huge mobilization of testing teams. And they actually have compared the current deaths to expected deaths under normal conditions, and there don't seem to be anything in South Africa in the way of hidden deaths. So those numbers seem to be the numbers. And in Nigeria as well, while the testing has not been as good, we see a pattern that is quite similar to the South African one. So this idea that it's just a testing issue, I think, has to be called into question. There's also the demographic concerns, and thinking about the ways in which demography, the very young population in sub-Saharan Africa especially, relates to the demographic profile in Europe. And as you can see here, the European profile has quite a number of people from 65 on up, which is normally recognized to be the kind of danger area for coronavirus, where the vast majority of deaths have been in Europe. And in Africa, 65 on up is quite moderate. But even within Africa, there are significant differences in the demographic profile. Not everybody has a pure population pyramid. In fact, in Southern Africa, the demographic profile is shifting a bit more towards the youth bulge. And you can see the South African profile there. A larger number of people over 65 and a more considerable youth bulge relative to Uganda, where you see a really pronounced population pyramid with a huge range of a huge share of the population under 25. And that's very much the case across much of Southern Africa. You have a slightly different profile that is more vulnerable to diseases of the aged, whereas in much of Central and West Africa, you have much more in the way of this strong population profile. This gives you a more comprehensive picture of the range of population. So you can see Southern Africa and North Africa, you have an older population profile, nothing on the scale of Europe. South Africa is about 6% of the population over 65 relative to about 24% in Italy. But definitely you have younger populations throughout the bulk of Africa. A little bit of aging in Kenya, Gabon, CAR, but for the most part, the aging populations are concentrated around Southern Africa. So that certainly shapes a little bit the vulnerability profile that we might be looking at across African countries, but also it's worth thinking about vulnerability in terms of health challenges. The deaths from coronavirus, as Simukai mentioned, are still under 4,000. And when we're talking about a disease like that, really the serious part is dying of it. If the risk of dying from it is high, it's a terrible disease. If you're just going to catch it, get a bit sick and recover, while they're still discovering things and there have been negative side effects, strokes, blood clotting, etc., mostly again in older people, for the most part, among younger populations, the toll on the population of just getting the disease and recovering from it is not nearly so bad. If you look at these less than 4,000 corona deaths against the disease burden and the death rate, the annual death rate in recent years from some of the major health challenges in sub-Saharan Africa, you have tuberculosis, over 400,000 deaths per year, malaria, over 400,000 deaths per year, diarrheal disease and death in childbirth, which are both of them signs of eroded, collapsing health systems, also in the hundreds of thousands. So the risk of coronavirus against some of these other things, which these are also death rate or numbers of deaths, the numbers of people affected by these disease who might have secondary consequences, secondary problems, are equally large. Again, this signals some differences. Tuberculosis is a major problem, particularly in Nigeria and South Africa, and is much more associated with health problems relating to the AIDS endemic areas of East Africa and Southern Africa, less in much of West Africa, whereas malaria is more endemic to West Africa and certain parts of East Africa. So the risks of these diseases have somewhat different profiles. Similarly, the whole idea of vulnerable populations, precarious workers being vulnerable to lockdowns and having severe threats to livelihood in the context of lockdowns. Again, you can see that while levels of informality across much of sub-Saharan Africa are very high, The reality is Southern Africa has much smaller informal economies than much of the rest of Africa. And you can see South Africa really, you're looking at about 30% of the non-agriculture, about 34% of the non-agricultural labor force, whereas in much of West Africa, you're looking at 75, 80, 90% of the non-agricultural labor force in the informal economy. So again, the patterns of risk because of large informal economies vary from country to country. And even the extent of coronavirus is quite different. And this gives you a sense of the corona hotspots. There is coronavirus, there are cases in most African countries so far, but many of them are in the 1s and 2s. The 2 worst cases in sub-Saharan Africa are Nigeria and South Africa. South Africa is really the worst, and then we have some West African hotspots, especially Egypt. So the question is, how does this balance of forces play out in terms of affecting the way that African countries have responded to coronavirus? It is interesting to note, and this is a map that shows, put together by the Blavatnik School, that shows the severity of measures against coronavirus, the extent of lockdowns, public education campaigns, testing, etc. And you can see that the severity of response is quite comparable to Europe and to North America. Certainly South Africa has by far the most strict regime in sub-Saharan Africa. Nigeria is painted as quite strict, but it's actually very, very mixed within the country. But for the most part, with the exception of Tanzania and a lighter response is actually Mozambique, Malawi, Tanzania, you have fairly strong, fairly stringent responses to coronavirus. And one might wonder, if the public health risk is relatively low, why such a stringent response when you have high levels of informality for the most part, a very young population, not much, not a very high level of deaths as a result of coronavirus compared to very high risk for a variety of other ailments. So it's worth thinking about the ways in which this has given rise to lockdown debates. On the one hand, does the lockdown approach make sense? Is it an appropriate thing for the African context? And what might the alternatives be? And certainly in the West, as well as in sub-Saharan Africa, the lockdown debates tend to center, as I suggested before, on a debate between the health concerns and the economic concerns. In the African context, the anti-lockdown debates, there was a really nice little blog by Melissa Leach and James Fairhead talking about, does one size fit all? Is lockdown an appropriate policy response in Africa? As I mentioned, very large informal economies averaging around 85% of the non-agricultural labor force. In a context of lockdown, it actually increases poverty and inequality, where those with some kind of internet infrastructure, middle-class jobs, can work from home, get some kind of economic support, is contrasted with a vast majority of the population that can do none of those things and depends on daily work in order to eat. Also the fact that much of that population live in slums. 2/3 of the urban population in sub-Saharan Africa are in slums, and no hope of social distancing, little access to water. All of the appropriate measures are extremely difficult for the bulk of the urban poor. The tension over social protection programs. Some African countries have emerging cash transfer programs, others very poor. The food distribution issues have been somewhat inadequate, and I'll look at that in more detail, but there is a sense that the large numbers of informally employed people living in slums are getting very little support through various palliative measures, food delivery, cash transfers, etc. And there's been a real shift towards authoritarian forms of lockdown enforcement rather than health-based forms of enforcement. And again, I'll say a few things about that, but definitely in Kenya and Nigeria by mid-April, more people had been killed in the enforcement of lockdowns than had actually died of coronavirus. And definitely in South Africa, Rwanda, and Zimbabwe, people were being killed in the enforcement of lockdowns as well. So the authoritarian forms of lockdown enforcement, rather than a more public health-based enforcement, were a source of problems. And all of this really has been pulled together into a concern for cut-and-paste policy solutions, but then a shift towards a different kind of cut-and-paste policy solution, which was, instead of lockdowns, huge mobilization of aid and a push for universal basic income and cash transfer systems for people in lockdowns. And we've seen similar calls in the UK that there are too many people who fall through the cracks of protective measures, and we need to think about a universal basic income. So I think a concern that is increasingly raised, and Andries du Toit in South Africa has written about this, is that this lockdown debate is too simplistic. It also is reproducing concerns from the West. And if one size doesn't fit all, what are the other sizes? Are there other sizes within Africa as well as outside Africa? And I want to suggest that there's a need to focus more on the internal social and political processes in particular African countries relating to the nature of the state and the electoral system. The size of the informal economy, as I've pointed out, is different. The different capacities of health systems, the extent of urbanization. Some African countries are more urbanized than others, and so large informal economies and concentration of people in slums are less of a problem than for others that are highly urbanized and have very large informal economies and slums. And finally, the importance for different African countries of international signaling. So I just want to look at two pairs of African countries and look at how the lockdown situation or the policy response has varied between those two when we look at the kind of push and pull factors influencing lockdown processes. So the first two are South Africa and Nigeria. These are high outbreak countries. These are the two countries with the highest coronavirus outbreaks in sub-Saharan Africa, but very different lockdown responses. And that can be traced, if you look in a more fine-grained way, to differences in the political and social and economic realities of those two countries. And among the things that jump out immediately, South Africa has a slightly older population, more of an aging demographic structure, more people over 65. It is highly urbanized, but it's also very high international exposure, but it has a comparatively small informal economy, though a high level of unemployment alongside it. It has responded effectively with a very strong lockdown, the strongest one in sub-Saharan Africa, but has been able to use its previous public health issues, particularly its struggles with HIV/AIDS and tuberculosis, to mobilize pre-existing health worker teams, screening teams, had 28,000 screeners, health workers out in the month of April, screening people, and as I mentioned, have managed to screen roughly 1 in 10. Now, for a country about the size of the UK, that really puts the UK to shame. It imposed its strict lockdown before the first death was reported, so was really following what was going on in the international community and trying to take appropriate measures in advance. Again, not a great comparison if you look at the UK. And has mobilized resources for stimulus packages for businesses to keep the economy going, though the whole issue of palliatives, distributing food to the population, has mostly been done by NGOs and religious groups rather than by the government. The government has had a much more authoritarian response to lockdowns in a lot of the poor informal housing areas. Now, one of the things that you notice in South Africa is that although there's a strong health response and a considerable measure of vulnerability, there's also very limited resistance because the informal economy is small and politically quite weak. There is a strong cash transfer system, so there are measures on the ground to get resources out to the poor, even if not the food that they need if they can't go out to the store. There's no impending election, although there's an increasing politicization of the lockdown, and the opposition party is now doing pretty much the reverse of what's going on in the US. The opposition is lobbying for freeing the people, while the government is really trying to continue to enforce a lockdown, but is lifting it under pressure even earlier than some people feel is appropriate. And very, very strong international signaling because of the financial and digital and mining dependence of and tourist dependence of the South African economy on people from the West being willing to come to South Africa. Now, if you compare that to the Nigerian case, you have a pretty similar level of vulnerability for slightly different reasons: highly urbanized, high international exposure, but a weak health system. Though the experience of Ebola and polio tracking actually gave Nigeria a bit of a head start on keeping on top of things at the beginning. They have imposed only partial lockdowns, really by state. 3 states were put into lockdown by the federal government. A few other states are doing degrees of lockdown. Some are just imposing curfews, which is an interesting trope, as Simukai raised. The trope of the curfew as a way of locking down against a virus really kind of makes you wonder if the tropes fit the disease. And a promise of distribution to the poor, an attempt to distribute palliatives, but the minister in charge actually announced that the palliatives that they have weren't even going to be enough for up to 25%, up to a quarter of the people in poor areas who needed them, and the actual distribution was even worse. But in Nigeria, there has been heavy resistance to the lockdown, partly because you have a younger population, less vulnerable, very large informal economy, very much in need of getting out from under the lockdown in order to earn a living, very poor social protection infrastructure, almost negligible cash transfer activities. There is no election there. But there's a strong division on international signaling. A number of states are very much focused on signaling to the international community that they are worthy of loans, that they are modern and looking towards a kind of good governance, modernizing economic system, particularly in the Southwest, and also the governor of Kaduna State in the North. And there are a number of others who are much more populist, turn to religion, encourage people to go and pray for the Eid, much more pushing for not paying much attention to coronavirus, which is a Western disease anyway, and it's brought in by foreigners. It's not really a serious thing, and a whole proliferation of various types of myths of what corona is all about. And these contrasts can be shown in these pictures. These are the coronavirus isolation centers that are being built in Lagos in the Southwest. And this is the Eid prayers in Nigeria, in Kano on the left, and in Borno State on the right. You can see certain gestures to the coronavirus context, a little bit of social distancing on the inside, but if you look at the Kano context, the people behind the screen on the outside, they're pretty tightly packed together, bit of masks going on, but for the most part, people are coming out and doing their Eid prayers. On the invitation, certainly in a number of these states, on the invitation of the governor, who said that they should come out, they should say their prayers, but they should wash hands and practice social distancing. So the question is this irresponsible? Or is this a recognition of popular needs and a concern for electoral popularity in a context in which you have very high levels of poverty and very limited capacities for sustaining a lockdown? Sorry, it jumped to, I know I'm probably over my time, so I'm just going to go, sorry, this keeps jumping. I'm just going to go very quickly through a second pair of cases, which are moderate outbreak, but also very different lockdown behavior. And these are Kenya and Tanzania, neighbors, basically, both East African countries. Different levels of vulnerability. Kenya, slightly more aging population, but quite urbanized, highly internationalized with the tourist industry and the ICT industries taking off there, a real modernized, technically modernized economy kind of image, and a moderately good health system. But the resistance in Kenya, there's been quite a strong lockdown, much more limited resistance because of a very, very high security response and a slightly less politically influential informal economy. The informal economy in Kenya was relatively moderate until quite recently and still is mostly confined to the lower end of the economy, whereas in West Africa, you have much more informal activity at the wholesale level, at the international trading level as well, whereas in Kenya, there's much more is at the micro enterprise level. And they have, in Kenya, no upcoming election either, but really the lockdown is being treated as a law and order problem with very high levels of police brutality, and is really serving to reinforce state authoritarianism in the Kenyan context. In Tanzania, you have a younger population, one of the much younger populations in the African context, urbanized, but somewhat less internationalized, and a very strong resistance to lockdown, both from the state and from the population, partly because it has a very large informal economy and partly because it has an upcoming election. I think it's this coming year, actually. I shouldn't have put next year. There's a very populist response by their populist authoritarian president who encourages people to socialize, to work, and to go to church. There was a big Corona party in Dar es Salaam this weekend. And when rising cases of coronavirus and rising death figures were reported, and this earned them being chastised by the WHO, Tanzania has just stopped releasing figures. And for several weeks, there are no figures whatsoever coming out of Tanzania, and they continue to have a kind of public education campaign of washing hands and socially distancing and wearing masks, but moving around as normal and very much going to church, a lot like what's going on in Brazil right now. Okay, so we can see that there are a whole different range of pressures that lead to the kinds of responses, lockdown responses going on in sub-Saharan Africa, but international agendas are quite prominent. What I want to emphasize is the need for a little bit less of an emphasis on trying to insist that African countries must follow international protocols, whether it is of health protocols or cash transfer, the implementation of universal basic income debates, and looking at the needs of the society and the economy. More attention to the internal balance of forces, the internal needs, what kind of political pressures are in place, the way that upcoming elections create pressures for governments to respond in certain ways, but also adapting solutions to the needs of the population. Community medicine, social training in social distancing, creating forms of hand washing, social distancing practices that are possible in local conditions, popular education, a certain amount of community tracking and testing where possible, and attending on the opposite side to the risk of massive waste of resources on vaccines and diversion of public health priorities to coronavirus, which does not seem to be a huge threat to the African context, and looking at other ways of controlling the virus in order to mitigate the risk of wider infection. Obviously, African economies are very much dependent on being able to export and on investors and international donors, et cetera, feeling safe to come to Africa. But being very careful about the ways in which enforcing one or the other of the two templates of coronavirus response may waste resources, may intensify inequality, and may intensify authoritarianism with the state, and adapting things not just to shift to one size fits all for Africa, but to a much more differentiated response that takes account of the needs of African societies. And I'll stop there.
Great. Thank you, Kate. Thank you, Simukai. And thanks everybody for the questions that you've put in. I'm gonna, as moderator here, I'm gonna start by, there's 4 questions that came in that are sort of, I'm gonna call them sort of the data and the science questions, and then we can turn to some more of the analytic questions. But the first questions is that one person points out that actually the testing in South Africa is not 10%, but was 1%, and wanted that to be clarified. That's another person has asked whether or not African countries typically comply with death certificate protocols. So is it possible that deaths by COVID or even ordinary casualties are not being recorded in the national statistics? Another person asked a question, which I think you've both sort of addressed, is saying the answer might be maybe, which is that, is it possible that the pandemic peak has not yet happened in Africa and that the worst imagined scenarios will become true in the following weeks or months? And then just to lump these sort of data science questions together, there was a question about the relative degree of sort of infectiousness of TB, malaria during childbirth relative to COVID. So let's not spend too much time on these, but these are sort of, I think, important data questions to clarify before we then move to the more analytic questions, which I can follow up with from the Q&A.
So I'll maybe comment on a couple of those questions. I mean, the one that we've already sort of dealt with is, are we essentially pre-peak? Is this, is the worst yet to come? And yeah, the answer is maybe. That's a very possible scenario, and we don't really know yet. And a lot of the models and the projections could point in a number of different directions. So I think that the key thing now in this period of uncertainty is, where possible, time being used to gauge appropriately what's happening in given contexts and countries to prepare in the event of a rise in cases. The question about death certificates and documenting documenting mortality. So this is a murky one, and it's difficult, right? I don't think anybody knows for sure what death certificate practices are across the continent. But what we might look at are excess mortality within given populations. So we have background, or epidemiologists would have background death rates year on year or month by month in different populations. And we can look at whether what's happening at the moment is bucking those trends for deaths that are occurring, particularly in hospital and some of the community deaths. So I think that this measure of excess mortality will be the most useful way of distilling whether there's been a sharp spike in deaths, even if the death certificate does not document COVID-19.
Okay, I stand corrected on the level of testing. This is part of what happens when you're pulling together newspaper reports madly in countries that are less one's focus. But the core point there, I think, is that the testing and tracking in South Africa is quite impressive relative to even a number of European countries, and certainly quite impressive relative to the UK. The part of that is that they had teams of trackers already in place when this thing started. Part of it is past experience tracking the illness under HIV. But there is considerable evidence that they have done quite an impressive job on the testing and tracking level. The protocols of recorded deaths, I think, except maybe in South Africa, that's not really the issue. I mean, Tanzania doesn't even record anything. It doesn't even report figures. Nigeria, many people are fleeing the quarantine centers in certain states because they have nothing for them. They're not looking out for them. They just go home and do home remedies and try to manage things. In some states, they're better prepared than in others. But a lot of there were unreported or unattributed deaths, a huge outbreak of them in Kano a few weeks back. They have figured out that a number of them were corona deaths, but the fact is that most of the people, the medical personnel, had fled the hospitals and the testing centers because the public health provision was so poor, and they really didn't feel that they were being properly supported. So I think the recording of deaths is being done more through newspaper reporting, various types of centralized agencies trying to figure out how many people have died. But some of that actually involves, what do they call, oral autopsies. Certainly in Nigeria, they've been using that, where they interview local people and get them to describe how this person died and what the symptoms were, and try to work out whether these are corona deaths or not. So there are a variety of different ways of recording these deaths. Whether we are pre-peak, I don't know, but I do know that we're talking about human beings. If you take the curves from the first death and follow what's happening, certainly there is a different path in Africa. Deaths seem to be rising, but you saw that curve very, very, very slowly. The doubling every day kind of thing that was happening in Europe does not seem to be happening in most African countries. The way that curve is increasing despite very poor public health systems. So whether we're pre-peak or post-peak, I can't say, but the way that peak is happening is very, very slow.
Great, thank you. So the next question here is the question for Simukai, and this is from Laura Mann at LSE. And Laura asked, I'm going to sort of paraphrase what she wrote, but she was asking, in the context of thinking about fiscal health states and fiscal military states, that war mobilization can create long-term capacity, she'd like to ask if you've thought about this idea in relation to one of your final points about disease exceptionalism. Have previous epidemics shaped state building around certain features of diseases, whether they be along fiscal lines, interest groups, or state society infrastructures?
Yeah, thanks for that, Laura. So it's quite a historically contingent question. I think different pandemics at different points in time have led to different kinds of social reforms, or have reinforced pre-existing structures. I think that the kind of contemporary, by contemporary, I mean, in the last 20 to 50 years or so in Africa, when we look at some of the major epidemics that have occurred, disease exceptionalism often reinforces a logic of vertically targeted disease-specific models of public health. So for instance, HIV is the exemplary case. as HIV kind of expanded, or HIV programs expanded throughout the African continent, these were initially implemented in such a way that they were kept sort of separate from, rather than integrated into other and wider forms of social welfare and public health or of primary care. And that's a risk that's always existed there. Parallel funding streams and also internal migration of healthcare workers from, say, your typical government-funded clinic into something specific to an HIV treatment center. That has started to change, and there's ongoing debate within the global health community about trying to take those infrastructures and then reorienting them. But fundamentally, I think that the track record of disease exceptionalism tends to create much more medical pluralism and institutional fragmentation than it tends to bolster public health and welfare.
Great. Thank you. So Kate, one of the questions here I think is, I mean, you can address this as well, Simukai, but do you have any comments on the circulation of social and biomedical conspiracies? For example, tests are tainted to wipe us out, or hegemonic powers are imposing their solutions in spite of African solutions. For example, Madagascar's herbal drink. There's another question here about there's a few questions about Madagascar as well.
Okay, I've been sort of keeping an eye on some of these myths and narratives that are coming up. I think Simukai also has been looking at them. But the issue is, some people have referred to it in Nigeria as an infodemic. There is so much cross-cutting information, myths, home remedies, etc., coming out about coronavirus. And this is in part symptomatic of poor public health systems and poor public information, so that people feel that, what's available to them is not helping them, and they come up with their own solutions. It's partly also the politicization of the pandemic, in which there's an effort to peel people away from international narratives through the propagation of other types of narratives. And I think that's one of the ways in which Simukai's work is quite interesting, because often what's going on is not just one narrative, but competing narratives. That coronavirus is a Western thing, and it's only middle-class people who travel abroad who have to worry about it. Real, proper Africans who live in Africa are not vulnerable to it. A whole range of home remedies, partly because what's available in some of these isolation centers is simply not healthcare. It's in Nigeria, I've heard in some of the northern states, get a bit of paracetamol and not very much care, and people feel that they're better off at home. So this, there is, of course, the reviving of old narratives as well, and that's been quite common, particularly in northern Nigeria, in which a lot of the Muslim states are circulating narratives that this is an effort to wipe out Islam, to stop people from praying, or to sow disease among Muslims, and that the solution is to refuse lockdowns, to refuse to cooperate with Western health advice. Interestingly, in Nigeria, to refuse to accept the advice of, or in fact the orders of, the Sultan of Sokoto, who is supposed to be the leader of Muslims in Nigeria, to stay home and not pray in group prayers for the Eid, but simply responding to populist calls by governments, by governors, to come out and pray. So you have, I think, in the same way that fake news is used in the US in times of politics, in various parts of Africa, you're seeing a real politics of fake news around coronavirus that is telling, is trying to position competing narratives about what's going on and who you should listen to.
Okay, thank you. Shoot, there was a question here that caught my eye that I wanted to get to you both, and I can't seem to find it.
Maybe Simukai could come in on the myths if he has any reflections. While you're looking for the
yeah,
question.
Simukai.
Yeah, I mean, you know, really agree with what Kate's already outlined, that there's a lot of myth making that happens at a time like this. I think, you know, biomedicine has this very complex and ambivalent legacy on the African continent and continues to do so. Tremendous forms of power in here within not only biomedicine in the immediate sense of drugs and treatments and so forth, but the kind of wider social life and institutional forms within which biomedicine is delivered. And it's a real axis of inequality across the continent. And so I think that that plays into various ideas of where power exists and who yields it. And we do often find counter narratives emerging or containing certain kinds of critiques of power, as well as a scramble to shape different kinds of public expectations and narratives. But from a very orthodox medical perspective, I would be, you know, deeply troubled or worried about imbibing ideas that herbal tonics are a kind of cure or a deus ex machina out of a pandemic of this kind.
Great. So I think one that follows from that is a question from a former LSE MSc student, Noble. It asks, whatever modernity consists of, it must include science and a large size of economic formalization as opposed to large economic informality. Do the panelists agree? If yes, what could be done to introduce this actively on the continent? In 30 seconds. No, we have time for that. That's, I don't know, maybe you can both address this. I'd love to hear what you both have to say about this.
I wonder maybe if I'll come in on some of the science component, and Kate can tackle the question around economic informality. Yeah, I mean, I think, so the state of science on the African continent is dynamic in pockets, but largely grossly underfunded through many other parts of the continent. And we see a lot of, if you like, extraversion, where African science, or Africa as a site, particularly for global health science, has shifted over time in its positioning relative to the ebb and flow of academic and intellectual and scientific trends within global health. So, you know, one illustration of this, just to concretize the point, would be, you know, throughout the 1980s and the 1990s, in response to HIV, Africa was largely being framed as a kind of backwater, that Africans could not cope with or deal with very sophisticated or expensive antiretroviral treatment regimens and so on. And through a combination of civil society activism and politics, that sort of changed. But then we saw a reinvention of global health's relationship to Africa, wherein Africa became like a new frontier for scientific discovery. So huge amounts of funding being poured into doing research in like low income or resource poor settings, and the opportunity to kind of innovate scientific fields in that way. And so I think that there are these really interesting and quite intense political and political economic struggles that relate not only to knowledge production, but to the institutional forms that it takes with respect to science. And I think what gets lost in the process is the role or the prominence of African scientists themselves being at the forefront of setting health research agendas. And certainly a lot of work that's being done with scientists is that the disparities in the availability of money is so great, and in funding is so great, that it becomes the opportunity to be involved in global science often comes with having to play into this idea that Africa will be, you know, an intriguing or interesting place to, you know, test these innovative solutions and so on in a resource poor setting. There are changes afoot. I think the African Academy of Sciences is doing interesting work, and there's increasing social science documentation about the social and political lives of scientists that might complicate that picture. But it doesn't necessarily resolve, at least in the short term, the big sort of structural inequalities that extrovert the scientific enterprise.
Super. Kate, do you want to address the informality part of that?
Sure. I'll touch on both. On the informality part, I would say the informality is part of the science. The way this ailment affects the large share of the population in informal economies is part of the distinctive type of science that's needed in African countries with large informal economies. And frankly, by European standards, even South Africa's 30-odd% of the non-agricultural labor force is quite large. It's also part of the science to understand how risk profiles shape popular behavior, and public education campaigns that say, stay home, but if you do stay home, your risk of dying because you can't work and can't get food may be higher than your risk of dying if you go out and work. Those have real political implications, and the science and the politics has to take account of the distinctive structure of African societies with large informal economies and very different risk profiles in terms of age, but also in terms of the economic risks. But I would like to add as well, I thought it was interesting, Simukai's earlier comment, that African countries are not treated as part of the innovation profile for solutions to COVID-19. But the fact is that Senegal has been very active looking at a range of medical innovations. They were part of the research on the role of chloroquine, which we've heard various things about and hasn't always been the most constructive innovation, but also on new, cheaper types of tests. Ethiopia and South Africa have been frontline innovators in public health responses, in community health workers in low-income environments, and have been very successful in the tracking and testing by adapting those processes to the community health environments. And it is worth noting that in Ethiopia, the health minister who developed their community medicine system is the head of the WHO right now. So the science is part of understanding how African societies are set up, how their institutions work, their public health capacities, and what kinds of innovations would work in that environment, in those environments, relative to what works in the West.
Great, thank you very much. Another question that is here that I wanted you to ask is if you have, and this is for either of you, if you have anything to say about the role of the African Union in responding to COVID.
Do you have, I would just, I think it's been very much a kind of global conduit. It passes the message on from donors. It has encouraged a serious coordinated lockdown response. So it's very much about a coordinated response, but not always as helpful in engaging with the huge variation in conditions across African countries, the huge variations in capacity. I would say that it certainly has a positive role to play, but sometimes it's turned a bit more towards international narratives than might be as helpful as it would be if they also turned a bit more towards local realities and helped find an interface between the two.
Simukai, do you want to add anything there?
Not specifically to the African Union. I think maybe what has been interesting in this outbreak that is a bit new is that the new African CDC, Center for Disease Control, has gained in prominence and public standing in terms of shaping some of the scientific responses across Africa and generating knowledge about what's happening on the ground. So that's a new kind of institutional form that's trying to take a more sort of Pan-African view of disease on the continent and on this epidemic specifically. I think that its legacy or its trajectory is yet to be seen. It's kind of modeled on the American Center for Disease Control, and I have some misgivings about that. I think partly for reasons that Kate has already outlined about following Western sort of trajectories, but at a continental scale. Nevertheless, it's also a conduit potentially for a coordinated and Africa-specific mode of response. I don't know. It could go either way.
Great. Okay. So I think we're getting awfully close to 4:30. So I'm not sure that I think we should probably wrap up there. There's a lot of interesting questions left, but given how close we are to the time. So I'm going to thank Kate and Simukai on behalf of both Diego and I, and thank everybody for attending. And this is recorded and it should all be available by podcast. One thought that was on my mind just during all this, as someone who looks at some of these issues in Latin America, is that, I mean, there's huge informal sectors in Latin America. Latin America was just as gray on your map, Simukai, as Africa. And so at some point we should have another conversation about, and you know, some of the geographic, temporal things. I mean, Brazil has all the same different tropical zones. At some point we should have a larger discussion about how things are played out. And I guess I would just say that I hope that you're right and that things aren't as bad in Africa as they've now become in Latin America. But a month ago, people were thinking that things weren't that bad in Latin America, and it's a disaster now. But that's for a different time. Thank you, Simukai. Thank you, Kate. And thanks everybody out there. And our next session will be in 2 weeks, and we'll send out the announcement for that in due course. Thank you. Bye-bye.
Thank you.